Hi everyone, my name is Gabriel Altit. I'm a neonatologist at the Montreal Children's Hospital, and today I'll be speaking about the echocardiographic evaluation of pulmonary hypertension. I'm giving this talk in the context of the functional neonatal echo workshop at NeoHeart in New York City. And I really want to thank the organizer for providing me this opportunity to present to you guys and to present at this wonderful workshop. So these are my disclosures. And I've put here the QR code to access the content of these presentations that will be at NeoHeart. So at the end of this session, a participant will be able to outline some of the key echo markers to be evaluated in the context of neopulmonary hypertension. We'll describe some marker for assessment of RV and LV function, and we'll try to incorporate some of the concept of systemic to pulmonary ratio in the assessment of neonatal pulmonary hypertension. A brief definition, pulmonary hypertension is high blood pressure in the pulmonary compartment, and similar to systemic hypertension, which means abnormally high blood pressure in the systemic compartment, there are multiple etiologies to that. So you could have things like BPD that could be causing an abnormal pulmonary vasculature and pulmonary parenchyma. You can have a pulmonary embolus that will block the pulmonary artery and lead to high P pressure. You can have left ventricular dysfunction or mitral stenosis or pulmonary vein stenosis that will increase the pulmonary venous pressure and lead to high PA pressure due to a post-capillary phenomenon. And really, to be able to treat this picture of pulmonary high blood pressure, you need to address the underlying etiology. And sometimes you may have high PVR with no significant increase in pulmonary pressure because you have a duct that offloads your PA pressure. So sometimes you have to be careful about the word hypertension if you're trying to tackle the idea that this patient may have suprasystemic pulmonary vascular resistances, because we know that pressure is a function of flow and resistance. And so typically, we know that after birth, we get this significant drop in pulmonary vascular resistance and significant increase in SVR due to the disconnection of the placenta. And, reaching about 3 months of age, we should all have a P pressure of about 15 to 5, systolic and diastolic, with a mean around 10. And after 3 months of age, if you have a mean pulmonary arterial pressure above 20, that would be considerations for pulmonary hypertension or high blood pressure and pulmonary vasculature. And obviously, there's many caveats to the consideration within the babies, and that's why echo provides you a lot of information about what you need to tackle to improve the condition of your patient at bedside. And so we'll go over some of the basic concepts of pulmonary hypertension, the use of targeted neonatal echo. Some of the tables that I will outline here have been produced from a review we've done with Dr. Neil Patel, Florian Miller, and Annie Lapointe in the context of CDH, but I do believe that these concepts are applicable to many population that we care for in the neonatal population. So key concepts are, well, first, we would like to assess PA pressure or pulmonary vascular resistance as, at least PA pressure as an indicator of pulmonary vascular resistance. One of the common ones is tricuspid regurgitation. So when you do have tricuspid regurgitation, you get a flow that's created from the RV to the right atrium. And this flow occurs at the peak of systole. And so if it's at the peak of systole, you get an estimate of the peak systolic velocity between the right ventricle to the right atrium. And so theoretically, your right ventricle will equalize pressure with your pulmonary artery at the peak of systole because the two structures are connected together. Knowing that we can use what we call the Bernoulli concept or the Bernoulli equation, we can translate the speed of this reflux into a pressure gradient. There's obviously many caveats to this concept of Bernoulli, but theoretically, the pressure gradient is converted via 4 times velocity to the square. Here you're obtaining a Doppler through this tricuspid regurgitation, which tells you that the speed of regurgitation occurs at 5.5 meters per second. And so if you put it in this equation, it tells you that there's a pressure gradient between the RV and the right atrium of a peak of 119 millimeters of mercury at the peak of systolic contraction. So assuming that the RV and the PA are interconnected and they have the same pressure, you can assume that at the peak of systole, you get at least 119 millimeters of mercury. And that would be assuming that the RE pressure is 0. Now, in most contexts, a structure that has some degree of filling will never be 0 millimeters of mercury. So the RE is typically between 2 to 5 millimeters of mercury. If you obviously have RV failure and your RE is not able to empty into your RV, the pressure may build up into the right atrium, especially if there's no pop-off, such as an atrial shunt that would pop off the pressure from a right atrium into a left atrium. And that's why a lot of kids who have RV failure will have high RA pressure, and eventually their liver will start becoming very significantly distended. And so in this particular echo, the RV systolic pressure would be estimated at around 119 plus the expected right atrial pressure of about 5. It would be 124 millimeters of mercury, which is extremely high for systolic blood pressure. So we can compare this to the to the systemic compartment. And if we have a systolic blood pressure, this would be twice systemic if the systemic BP was 65. And so when we measure it, we try to get the chin, really the chin here, and not the beard or the little hair that are often artifactual. This is another example of tricuspid regurg with blood going away from the probe. So it's blue in an apical four-chamber where you have the RA and the RV. This focus is on the RV. And you can see that at the peak of systole or peak of contraction after the QRS, you get this blue jet away from the probe. Another example here where it's 51 millimeters of mercury. So ideally, your line of interrogation needs to be in the line of this jet in order to estimate the speed of this jet as accurately as possible. Another example here where you can see that the jet is going probably this way, and then the line of interrogation attempts to be in the same direction, and we get 113 of RV-RA gradient. A second opportunity we get in babies is typically the ductal flow pattern. So the ductal flow will inform you on the relationship between the PA and the aorta. And obviously, if your PVR are higher than your SVR, you should get a right to left shunt. If your SVR are higher than your PVR, you should get a left to right shunt. And if they're about the same, you should get about a bidirectional shunt. Now, when the PDA is large, obviously it will pressure and flow transmit. So the two connected structure will equalize in terms of pressure. Doesn't mean they'll have the equal amount of resistance or equal amount of flow between them, because these will obviously adjust depending on the PVR or the flow transmission. So this is an example of a bidirectional PDA, which is a bit restrictive, so has a tendency, as you can see, to restrict pressure transmission. So this is a CDH patient who has a bidirectional shunt, and here the gradient is about 30 millimeters of mercury just after the QRS, telling me that the PA pressure is about 30 millimeters of mercury above the systemic pressure in this particular patient at the time of assessment. Same thing when you have a large duct, you can get a bidirectional shunt, but this time the velocity are very low because you get a rapid equalization of pressure between the two compartments, considering that this duct is very large. But you can see the blue and the red telling you that this is bidirectional. Here, this is the context of a duct that's very tiny and restrictive. You can see that there's a gradient at the peak of systole of 46. This tells me that there's suprasystemic PA pressure and likely suprasystemic PVR that's driving this suprasystemic PA pressure. Now, you could see this context also in a patient who has extremely low aortic pressure, such as in the context of a coarctation or interrupted aortic arch. So don't be fooled just about the PDA directionality. You have to put this into the context of the overall big picture. If the patient is in equalized sepsis and has very low systemic pressure, there may be a right to left shunt at the duct just because the PA pressure is higher than the LV pressure, the aortic pressure. This is a very large duct that's unrestricted. You can see that there's very low velocities here, less than 1 meter per second, but it's completely right to left. So this tells me that the PVR are likely higher than the SVR, but probably the PA pressure is now the same as the aortic pressure just because this duct is unrestricted and transmits pressure from one compartment to another. Again, this could be because of very high PVR, abnormally high PVR. It could be because of low SVR. It could be because of combination of both. And we'll go over some of these concepts in, I believe, my talk on Thursday at NeoHeart. Pulmonary insufficiency jet. So the pulmonary valve will close in diastole. And so when there is pulmonary insufficiency, you get a PA to RV blood flow. And the speed of this blood flow could also be assessed for the gradient of pressure between the PA and the RV. And so knowing that you have a certain velocity of, for example, at the peak here, you get 33 millimeters of mercury of PA to RV differential. Then obviously your diastolic pressure is probably in the zone of the 20 to 30 in this particular patient. And so we typically say that the mean pulmonary arterial pressure is 4 times the early diastolic PI to the square, which is the Bernoulli equation, plus the estimated RA pressure. Why the RA pressure is because the RV is connected to the RA during diastole. Basically, the tricuspid valve's open, RV and RA pressure will be the same. And so in this context, knowing that babies after 3 months of age should have less than 20 millimeters of mercury of mean pulmonary arterial pressure, having 37 would definitely be abnormal. Septal curvature. Septal curvature informs you on the relationship between what's happening in the RV and what's happening in the LV at the peak of systole. That's when we typically will evaluate that in relationship to the PA and aortic pressure. Why? Because the RV is connected to the PA and the pulmonary valve is open at the peak of systole. And the LV is connected to the aorta and the aortic valve is open at the peak of systole, which means that the RV should represent the PA pressure in systole and the LV should represent the aortic pressure in systole. And obviously it's not exactly the same story in diastole because at that point it represents end diastolic pressure when the pulmonary valve and aortic valve are theoretically closed. Unless you have significant pulmonary insufficiency or aortic insufficiency. So in the typical normal postnatal transition, your LV systolic pressure is higher than the RV systolic pressure. And when you're looking from on top, you can see that the RV is very thin and crescentic and looks like it's hugging the LV. And the LV is round, circular, and muscular. And as you get increased RV systolic pressure, if you get high PVR, for example, you get flattening of your septum and eventually bowing of the septum if the RV becomes suprasystemic. An example here where you see nicely this septum bowing and this RV that looks a bit dilated on top. And so just a reminder that when you get right-sided pressure higher than left-sided pressure, it could be because the right is abnormally high and more than the left, which is also abnormally high. It could be because the right is abnormally high, but more than the left, which has a normal pressure. It could be because the right is abnormally high, more than the left, which is abnormally low. So example, like an sepsis or very low LV output. It could be that the right is normal, but the pressure in the system is very low. And it could be that both pressures are very low, but the right is higher than the left. And that's true when you interpret septal motion, PDA direction, or VSD direction in systole. And that's an example of the continuum of increasing RV afterload and pancaking eventually of your left ventricle because the two ventricles are actually interconnected. More and more, the literature is going towards quantifiable measurements, and this is one of the measurements we can use to quantify septal deformation. It's called the eccentricity index, where we actually measure the diameter parallel to the septum and the one perpendicular to the septum, and we do a ratio of that. Typically, if you're a circle, you should be 1, and so values that are above 1.3 are typically associated with some degree of septal flattening and RV compromise. One other marker of increased RV afterload is the shape of the Doppler of the pulmonary outflow tract or RV outflow tract. This is an example of what a Doppler should be looking like. Typically, you get a Doppler will represent time on the y-axis and the speed of blood flow or velocity on the y-axis. And so this speed of velocity should be building up very smoothly and decelerating very smoothly. And when you start seeing like a very rapid acceleration with a slow deceleration, we start seeing patients with higher RV afterload. And then the afterload could be secondary to many etiologies like a PDA, like a pulmonary embolus, like high PVR, things like that. And then sometimes in the context of very, very high PVR, you can see some mid-systolic notching, and that's secondary to the recoil of the pulmonary artery, which creates a second phase of acceleration during the systolic ejection. And so because kids have higher heart rates, we will tend to measure the acceleration time, so the amount of time it takes for acceleration, here being x-axis, and we normalize it to the amount of ejection time as a way to normalize for heart rates. So this is an example of a very smooth Doppler, a pulse wave Doppler, which measures the velocity exactly where you're asking the machine to do so at the interrogation point. And here you can see that this is really, one that has almost mid-systolic notching here. Now, when we assess pulmonary hypertension, you always want to assess cardiac function. There's obviously the eyeball technique, which is not very, standardized in a way. It's looking at both ventricles in an apical view and saying, oh my God, there's biventricular dysfunction. I think more and more we're going towards what we call quantifiable assessments, one being using TDI. I'm not going to go over this. You can go on the website and read a lot on it at neocardiolab.com. But you can assess some of the velocities of myocardial motion, or you can use some of the time durations to assess a combined element of RV systolic or diastolic function. Tricuspid flow and flow velocities are more and more used to try to decipher some of the diastolic properties of the RV, although in the first few days of life, the RV is still in transition, and so these normative values are not necessarily applicable to what is pathological. Same thing for the LV. We can look at cardiac output. So this is an example of measuring the LV cardiac output, but the concepts are the same for the RV. So this is an example of an apical four-chamber view where we would get the Doppler of the LV and we get the LV outflow tract measurement, and we can use this equation to measure with heart rate and the weight, the cc per kilo per minute. And on the website, you'll even find a calculator of that. For the RV, you would measure the RV outflow tract as well as the VTI that I mentioned earlier. And there are more advanced markers like the systolic diastolic duration, which I'm not going to go over. We do like to have an assessment of also LV systolic function in the context of pulmonary hypertension because it could be secondary to LV systolic dysfunction and have a post-capillary phenotype. So this is an example of shortening fraction where you're measuring the diastolic diameter and the systolic diameter and creating the fraction of that. Ejection fraction being a fraction of the estimated volume. So this is an apical four-chamber view here and a two-chamber view at the bottom, where we use disc method by Simpson to estimate the volume at the end of diastole and the volume at the end of systole. And same thing in two-chamber, because these are not perfect circles, they're actually ovals. And it creates volumes. And with these volumes, you can do a fraction of the end diastolic volume and end systolic volume, giving you a ejection fraction. The right ventricle has also the capacity to, so it's very difficult to get an estimated ejection fraction using 2D echo because of the configuration of the RV. But what we can do is actually assess the fraction of area. So this is what we call the fractional area change, where we would trace the area of the RV and diastole and the area and systole and do the fraction of those in order to get an assessment of fractional area change. You can also look, this is the lateral and septal wall. You can also shift your probe and look at the anterior and posterior wall. This is the RV outflow tract and tricuspid valve. And you could measure the end diastolic area and end systolic area in order to get a fractional area change. And there are normative value per age for these elements. The other thing is that the RV functions as a longitudinal contraction. And so you can follow this longitudinal contraction by placing your line of interrogation at the attachment of the tricuspid valve to the lateral wall of the RV, and then follow the motion of this tricuspid valve from peak of diastole to peak of systole in order to have an assessment of RV longitudinal function. And usually about 1 centimeter is normal for a term baby. So this is an example of a kid with, some degree of RV hypertrophy and an apical four-chamber view. We see here a subcostal view where you see right to left shunting at the atrial level because it's blue. So from the right to the left atrium, the liver is here. And you can see that this M mode, motion mode of the tricuspid valve outlines a significantly decreased TAPC. Again, an example of a TR where you can get an RVRA at 94 millimeters of mercury. And then this is the concept of to measure RVO in the context of pulmonary hypertension. So here you have a pulmonary outflow tract with the pulmonary valve, and you get your 2-line of pulse wave Doppler, which provides you an assessment of the velocity of flow in the context of where you're querying it by echo. You can see that there are, well, not very nice, but QRS. The QRS is here, the QRS is here. And so you can trace the envelope of your Doppler, so time and velocity. So if you do time times velocity, it gives you a distance. We call this a stroke distance. And because it's basically an area under the curve, we call it the velocity time integral, which gives you the stroke distance. And you can then apply this stroke distance into the equation by measuring also the RV outflow tract. And finally, you can apply the concept of strain to both the RV and the LV, which measures basically how the perimeter is shortening during systole or expanding during diastole. I want to spend just a bit of time. Arch views are important, as well as pulmonary artery views, in order to make sure you don't have like either a coarctation or pulmonary vascular hypoplasia. That could be the reason why your patient has a high RV afterload. And so these are example of coarctation, and you can see that in coarctation you get a PDA that is RV from the PA to the aorta, so you can get differentials of SAD, but these are necessary because they provide blood flow to your lower organs. These are views from the subcostal views, where you get a left-right shunt, bidirectional shunt, or right-to-left shunt, which informs you on the relationship between the RA and the LA pressure. So I've put here some key concepts of how to manage some of your patients. I'll leave it as a resource. These are some of the pulmonary vasodilators, but I think that comprehensive assessment of pulmonary hypertension by TNE allows for targeted therapy to underlying phenotype. The curvature by the septum and the shunt directionality should always be interpreted based on the expected resistant pressure in the pulmonary systemic compartment. And outlining phenotype allows to avoid polypharmacy, track management and response, and optimize management and unnecessary medication. So thank you, and I'm available for any questions. My email is here. Have a wonderful day, and I wish to see you all at NeoHeart.